It's an absolute honor and privilege to be standing in front of my bio brothers and bio sisters and online as well. So a genuine pleasure to be here. We've all had, those of us in person have had a very nice lunch, and I'm here to warm you guys up here and online, and really be here to sort of get everything thinking about the clinical pragmatic approaches to looking after patients. So we've heard about the science, and we're going to hear a lot more about that. And what I'd like to do in the next 20 minutes or so is to look at how we apply this science to clinical need. And I think Gilles this morning came up with a really important phrase that technology is not a product unless you have clinical need. I think that's a really, really critical point, because we're all here to look after our patients and make sure their oral and dental health is optimum using all these amazing products, primarily the calcium silicates. So this is what I'm hoping to go through quite quickly, quite rapidly, just to give you that overview. And it is very much the restorative management. And I think that's a really important point. We've seen that there's the two clinical uses of these products in terms of restorative and endodontic. And I think we need to bridge that gap in the middle. So I'm approaching it from the outside coming into the tooth, and many of my colleagues will be approaching it from inside the tooth coming out. But we meet in the middle, and I think that's the key point. Dental caries is a big problem, huge problem. It's not gone away, and it's quite worrying that in the 2020s, if you look at caries and periodontal disease, it's the largest non-communicable disease on the planet, untreated. It's quite a phenomenal statement when it's a behavioral-related condition. So it's because all of us have a naughty gene, and therefore we like chocolate and we like sugar and we like all these things that are naughty, and therefore they cause a problem. So care is about being pragmatic. It's about changing behavior. We know the cost, so this is sort of EU costings from Stefan Lissel's team, and you can see there people perhaps underestimate the problem in oral and dental health that's out there, and certainly governments perhaps underestimate that. But I don't want to get too political, because I'll probably get myself into a lot of trouble, and I don't want to do that quite yet, maybe this evening. We know the issues that are out here. They're up on the screen, and we have a problem, and unfortunately the pandemic highlighted some of the problems, certainly in the UK, but also in many, many other countries, about the lack of access to proper care and the lack of prevention, because that's really the emphasis now with the United Nations, with the WHO, and all the other global bodies. We really need to be thinking about this. And the socio-economic inequities have absolutely bubbled to the surface and beyond in pretty much every country around the planet. So all the stuff we're talking about today is so critical in that overall management. As I said, we need to bring the mouth back into the body. There's no point thinking about the mouth on its own. We need to think in terms of general health. And as I said, it's preventable. And that's the frightening bit. With using a toothbrush and modifying your diet and some mineralizing agents, you can actually manage this condition. But often in many countries, the healthcare systems don't necessarily support a preventive approach. We have something called the National Health Service in the United Kingdom, an amazing organization that's looked after millions upon millions of patients for many years. But it's the wrong name. It's not a National Health Service, it's a National Illness Service. Because it's there to try to treat people who are ill rather than keep people healthy. It's a different philosophy. And the world we live in now, we can't just keep treating, we need to prevent. So it's building all this in. As I said, I want to make this really pragmatic. And, some deep questions after lunch. Why do you exist? Okay? Now, that we can debate for many hours. And for me, there's a huge debate why I exist, but that's another matter. But we all exist to help prevent and manage this condition. Many of us are clinicians are in the room, okay? And I always show this slide, and I ask people, what's the most important word in the title? And the majority of people always say prevent. They think they're being cool. They're getting the idea about prevention, and that's the wrong answer. The key word in that title is help. Because the only person who can prevent that problem on the screen is the person who owns that mouth. And that, again, is a key point, because what we do is repair damage, and we need to then guide and educate and encourage and facilitate our patients to look after their oral health. And this is where AMID, Advanced Minimum Intervention Restorative Dentistry, comes in. It's a treatment philosophy, if you like. Lots of writing on the screen there. It's giving you a definition, but I always show this slide, mainly because it took me 4 hours to create. It's my slight obsessive-compulsive disorder that I have, to align these cogs, all right? We all have it. We're all in a little bit like that, okay? And this was done on Christmas Day on 2013, genuinely, all right? That says a lot about the type of person I am. Anyway, but the point is, I show it all the time. I show this slide in every lecture because it's so important, because it's so obvious. When we're managing patients, there are 4 key clinical domains that we need to think about. You're all doing it already. The people online who are listening are doing it already. It's our colleagues who aren't here, who aren't listening, that I'm more worried about. We've got to identify what the problem is. Detection, diagnosis, investigations, all that sort of thing. Developing a personalized care plan, not a treatment plan. It's a personalized care plan. We've got to prevent lesions, control disease. Again, really critical. This is a lot to do with behavior change and behavior management of our patients. And this is team delivered. It's the whole oral health care team that delivers it. Of course, patients present with lesions and holes in teeth and infections and everything else, and we have to manage that. That's where minimally invasive comes in. So it's one piece of the puzzle. So MID, minimally invasive dentistry, is the operative bit, and it comes under the umbrella of minimum intervention oral care, which is what you're seeing on the screen. The most important domain, in my opinion, is the 4th one, the reassessment. It's bringing patients back. Longitudinal active surveillance, not monitoring. Monitoring is passive. It's a throwaway statement that we all learnt at dental school when we couldn't answer a question. So we say, let's monitor it. So what my students do all the time, all right? It's active surveillance. It's something completely different. So it's actually something positive that you're doing with the patient or the caregiver or whoever else. So it's team delivered. So this is the basis in which materials like biodentine fit in that minimally invasive domain. Those of you who are eagle-eyed will see that textbook on the screen. This is subliminal advertising, all right? So hopefully, Christmas is just gone. It's a shame. We should have done this just before Christmas. Then you could have bought it as a present for people, all right? But treat yourself, okay? But it's the undergraduate textbook. All of this stuff is in there. All the slides and everything are in there. And one of the key things that we're discussing in these 2 days is education. Getting this into clinicians' heads, and we need to do that right at the beginning. We've been doing that at King's for nearly 15 years, and many other dental schools for the same length of time. It's so, so, so important. So we develop guidelines. Our profession is bombarded with bloody guidelines. Pardon my language, but it really winds me up. We have too many guidelines, and we get confused by them. And people generate paper after paper after paper after paper, tweaking them every 5 minutes. Certain clinical disciplines are better than others. I'm not going to mention any names, but you can probably guess. In cariology and in operative, perhaps we've fallen behind a little bit, but guidelines do exist. They do exist, they're there, they're on the screen. And it's really simple and straightforward. If you're going to intervene, when to intervene in caries, you either do it non-invasively, as you can see on the left, i.e. what you would advise a patient to do at home. You've got micro-invasive interventions, so sealants, infiltration, and then you've got minimally invasive, when you're actually going in and doing something, cutting a hole. And the key features there are looking at lesion activity, when we're talking about caries, obviously, level of cavitation, and the cleansability of that cavity. So, the best clinicians on the planet always ask why. Why do we do something? Really important. You don't just follow like a robot list of protocols. You've got to think why, each step, why. So why do we excavate caries? If you've got a lesion, we've got a cavity, why do we dig it out? Why do we spend so much time teaching this? We initially thought that it was to prevent lesion progression, that we thought if we didn't dig it all out, the lesion would keep growing through the tooth into the pulp. We know that's not true. It's the bacteria in the biofilm that matter, not the bacteria within the lesion. That's why if you break down that biofilm and disrupt it regularly, you will not get lesions forming. It's as simple as that. I think we accept if you want to restore teeth for form, function, and aesthetics. I don't think anybody's got any dispute over that. But actually, the most important bit links back to this biofilm disruption. If we make the surface of the tooth nice and smooth, it makes it easy for the patient to keep agitating and breaking down the biofilm. So that's the reasons why we do things. And when we're looking at caries management, it's really that small amount of dentine that we're really worried about, as Amre was touching upon at the end of his presentation. It's this infected dentine, this contaminated dentine, which is soft, necrotic. Can't really do a lot with it at the moment. Maybe in the future we'll see, but at the moment we can't do a lot with it. So that's the stuff we want to remove. But you can see within the lesion, it's a really small amount. And the rest, the dentine pulp complex fixes. We're really lucky that we have this tissue within teeth, okay? And the whole purpose of endodontics is to preserve that tissue. And again, sometimes that's forgotten by some clinicians, I think. We want to keep that pulp going because it's way better than any of our materials or anything that we can do. That biology trumps everything. So if we look at caries removal, we can see an example here, and this is an example kindly given to me by David Ricketts, I think is coming today, I'm not sure, but a dear colleague of mine and many of you as well. We can see this lower molar on the radiograph. You can see the pulp chamber there. You can see the deep carious lesion, the radiolucency, very close to the pulp. This tooth gave positive sensibility readings, pulp tests and things like this. So this tooth is still kicking. The pulp's probably inflamed, absolutely no dispute, but it's still got a heartbeat. So what do you do when you excavate this? Well, when I was at Guy's, as it was then, King's now, 30-odd years ago, I was taught to do this sort of excavation. And my clinical tutors would come up to me and go, "Banerjee, that's superb." Because they could see the red dots. And they were very impressed by that. Okay? Because then we could take some setting calcium hydroxide, we'd put it onto these exposures, and then we'd fill the tooth up with amalgam. And I'd get a point to put into my book. All right? Because we used to collect points in those days. If you look at the radiograph again now, there's huge amounts of evidence now out there, and we're doing trials. Professor Jan Clarkson's in the room, and we're doing a big national trial looking at selective caries removal. So if we use that concept, so you can see on the screen where the dotted line is on the radiograph, and now you can see a different sort of excavation. Toffee fudge sundae excavation, I call it, for ice cream lovers. Okay? You look at that, and most of you, if you were teaching, you'd metaphorically smack the student across the head. I said metaphorically. I know you wouldn't assault anybody. I know that, all right? We'd argue that this isn't great. But yeah, apart from that loose dentine, we can sort of scrape off. But the key point here is we've got healthy enamel around the edge. And we've got moisture control. And we've now got brilliant restorative materials that can get a seal. And it's all to do with that peripheral seal. I always use the analogy of putting a cork in a wine bottle, very pertinent for France. All right, wine, cork, okay? How does a cork get its seal in a wine bottle? Peripheral. The cork against the glass. What does cork do? It expands, it contracts, just like our materials do. What does cork do? It breathes, just like our materials do, as Amre was just showing us, fluid movement, air, etc., etc. The only way this analogy falls down in my house is once the cork comes out, it doesn't go back in again, but that's another matter. So it's all about the peripheral seal. That's the key point. So we're pushing now more and more this concept of, for teeth with a pulp that's still alive and kicking, give it a chance. And this is a pragmatic approach. And remember, I said I'm coming at it from the tooth inwards as opposed from the pulp outwards. And you've got to remember the clinicians who are doing this in primary care are not first-class endodontists much of the time. So, and actually patients, if this is explained carefully, this is a pragmatic solution of managing and maintaining pulp sensibility and pulp vitality. So on the left, you can see a sort of complete caries removal example, and on the right you can see selective caries removal, but making sure the peripheral seal is achievable. So when we're trying to do our restorations properly, we need to think of three, you've got to juggle sort of three balls. We need to understand the histology of the tissues. And again, Amre highlighted that very elegantly, looking at the mineral, the collagen component, tubular structure, all this sort of aspect. Okay, so it's all about histology. So you have to go back to your textbooks and remember and understand what's going on within the lesion. We need to know our chemistry. When I was growing up at dental school, there were about 2 or 3 materials we could use, the main one being amalgam. Composite didn't work, bonding didn't work, GICs shriveled up in front of your eyes as soon as you placed them in a tooth, okay, in the 80s and 90s. Now, poor students have to learn 15, 20 different categories of materials, and they blur between the edges of when we should use them and how we should use them. Exciting for us, thanks to companies like Septodont and others producing these incredible materials. Very tough for students because it's quite difficult to now teach sort of in a black and white way that you use this material here and you use this material there. But it makes it exciting. But it's really important. And the other bit we're learning until the day we retire is the clinical aspect. So can we handle the materials properly, the tissues, the moisture control, the technology, the instruments, et cetera, et cetera. So if you meld all those together, you can start to do optimal restorations. And I think that's the key point where biodentine fits in. So as I said, why do we fill, restore cavities? And do we have these materials now? And clearly we do, otherwise we wouldn't be sitting here thanks to Septodont. So if you look, you know, as I mentioned already, we talked about direct and indirect pulp protection, pulp capping. Don't really teach indirect pulp capping anymore, thanks to materials like biodentine. All these principles are built into the restorative material. We don't need lots and lots of layers. We've got zinc oxide eugenol. We've got glass ionomers, flowable resin composites. The picture's slightly out of sync there. It doesn't matter. We have looked at sort of putting bonding agents straight onto some of this caries-affected dentine and infected dentine. All these things can work. We've talked about MTA and then leading on to biodentine. And this was really a revolutionary material 15 years ago. I would argue it still is. It's probably one of the cleverest chemistries that are out there in terms of material science that actually is effective in a patient's mouth and not just in a test tube in a laboratory. We've heard about the science. And I think we did some, Francesca Minocci and I were very fortunate to have an excellent PhD student about 10 years ago from Saudi Arabia who did one of the biggest first trials of the use of biodentine on patients. And we were looking, again, as Amre argued, using a comparison with glass ionomer. And we wanted to look at the outcomes of the pulp as well as the outcomes of the restoration and the sealing effect. So again, without going into massive detail, we put together a clinical trial which this young lady spent hours and hours going through lots of protocols and paperwork and ethics approvals and everything else. And those of you who do clinical trials will appreciate these things are not easy to do. And this was a split mouth design as well. So we needed patients with similar types of lesions on both sides of the mouth. So you could do biodentine in one versus GIC in the other. So we did all of this. You can see a sort of protocol there. And here's an example, one example of a patient and a tooth. You can see we're talking about deep lesions, but these teeth were still alive and kicking. That was the key point. So they weren't automatically root canal treatment patients, although for many clinicians they might well have been, because they would see this, look at the symptoms, go, right, this is an RCT. But we looked at this, you can see the clinical evidence there, what they look like, the excavation, which was minimally invasive, and then it was either GIC or biodentine. Then after a month, assuming symptoms are all good, the material was cut back and veneered with resin composite. And then reviewed at 6 months and at 12 months with radiographs and cone beam CT. And then we did a 2-year follow-up. So this is 1 year, then we did another 12 months. An interesting note, here's another tooth at T0 when it presented, and at T12 with the restoration with the open sandwich, i.e. you can see the composite hasn't gone all the way down the proximal wall. That was a clinical decision because it was going to be too difficult to do that in the mouth and maintain moisture control. And this is the other point with clinical trials in dentistry, is that there are so many other variables that we've got to think about that often confound data. But the key interesting bit was the radiolucency. Was that active recurrent caries or residual caries that's been left behind? Was it a leakage defect? Was it a lining? Or actually, as we've heard, thanks to the caustic etching of the high alkalinity of biodentine, is it something that the material is actually doing to the dentine itself? So these are all things we've got to think about when managing cases. That's data, don't worry about that, just for time. But what we found, out of the 55 patients, 70-odd teeth, 12 became non-vital after 1 year, 6 and 6. And then after the second year, only 3 more became non-vital. And it so happened they were GIC. We're not trying to conclude biodentine was better than GIC. We can't necessarily do that. What we're showing is the selective caries removal and careful maintenance by the patient actually worked in the vast majority of cases where the lesions were deep and symptoms were potentially moderate to severe. So that's the key point here. And we have materials that can actually allow us to do this. And you can see a nice clinical case here of the biodentine being placed, cut back about 3-4 weeks later, and then veneered with a resin composite. And you can see really good results there. So that was a real whistle-stop tour. As I said, if you hadn't gathered, there was a textbook with all of this in. But it's an undergraduate textbook going into postgrads, and really it actually maps patient care using that minimum intervention oral care concept, those 4 domains. So please, do consider that. There's a huge section on biodentine and calcium silicates in there. And of course, there's the book in your bag as well. So again, hopefully just about on time, but I'd like to thank you for your attention. Just a little flag for a conservative dentistry conference. There's not many of those left nowadays, but European Federation of Conservative Dentistry in Cordoba in Spain in April. Another nice part of the world, so if you're interested, do please look that up, 3rd to the 5th of April. And with that, I'd like to thank you so much for your kind attention.